Clinical documentation improvement, now also known as clinical documentation integrity, is a very important part of documentation as we know it today. The purpose of this presentation is to provide some basic education so that the documentation supports the codes and the DRGs that are used for reimbursement. When one looks at the vision of CDI, it is important to recognize these following points. Our goal is to achieve the highest order of specific, accurate, detailed medical documentation, whereby to ensure the most precise final coding so that the institution receives the optimal and appropriate reimbursement to which it is entitled. Next, to produce a medical record which is the most efficacious communication tool for all healthcare providers rendering care in each case. Also, to provide accurate, specific, detailed medical documentation whereby to effect enhanced patient safety as well as efficiency and effectiveness of care efforts. Next, to provide a medical record for external reviewers of all types, free of ambiguity, inconsistency, or clinical incompleteness. And lastly, to provide a medical record which is defensible relative to external audits. I do hear frequently, why does documentation matter? Well, it's a form of communication between fellow physicians, nurses, therapists, case managers, etc., to help ensure continuity of care. It also makes clear the intent or the plan for evaluation of the patient's condition. It creates a database to evaluate the effectiveness of the treatment and a permanent record to help with patients' future care. It also will substantiate appropriate billing and can also serve to refresh your memory and to justify and defend your care if needed. I also hear frequently who will be using your documentation, and I will frequently state that when it comes to physician-generated documentation, there will be anywhere between 15 and 20 non-physicians, maybe even non-clinicians, who will be looking at the documentation. But who's going to be using it? Other physician partners and consultants, nursing, ancillary staff such as PT, OT, social workers and case managers, and coders. On the non-clinical side, it may include billing justification, audit defense, malpractice defense, quality of care measurements, and government investigators. We also know that auditors are issuing a significant number of egregious denials, and that can make for a bad day. Listed here are a number of the organizations, the government organizations in acronyms that will be looking at the documentation and can provide denials. This changes from time to time, but at the present moment, some of the most common diagnoses being targeted by the auditors are cardiac arrhythmias, acute kidney injury, encephalopathy, severe sepsis, acute respiratory failure, acute renal failure, and many, many others. There are three words that we just hate to hear, and that is fraud, waste, and abuse. And just basic definitions are: fraud is knowingly certifying an admission as inpatient in which you are fully aware that it does not meet medical necessity and will be denied if caught by auditors. Abuse is damaging to you, the patient, and the hospital. For example, admitting a patient as inpatient for 3 days solely for the purpose of a SNF or nursing home placement. And lastly, waste. One study showed 25,000 of the nearly 618,000 hospital stays were inappropriate for inpatient but received SNF benefits. We know that some of this will be changing with the recent elimination of the waivers. There are basically 5 requirements for high-quality clinical documentation, and they are clarity, it must be clear, precision, we must have precise information, completeness, that sort of speaks for itself, consistency, and lastly, timeliness. It is important that this documentation is done in the appropriate time and follow the rules and regulations that have been established by medical record standards and regulations. Keep in mind that we must document smarter. There is no such thing as obvious or assumed in the medical record. Would it be obvious to a consulting physician, nurse, or trial lawyer? We must paint a clear picture with words. We must tell the patient's story and get to the point quickly, but don't miss the point in the process. I like to bring up the example of the movie The Ten Commandments, and how many times did Ramsey say, "So let it be written, so let it be done"? If it's not documented, if it's not written, although we don't write anymore, it wasn't done. So let's start with some basic definitions. First, principal diagnosis. This is defined as the diagnosis that is established after studies are completed. Key phrase, after studies are completed, and is the focus of the inpatient admission. The discharge summary is vitally important also to document the principal diagnosis, and the discharge summary can serve as sort of a rescue document. Although it can be identified after admission, the condition itself must have been, in retrospect, present on admission. This slide at first appearance may seem to be a little bit confusing, but as we all know, CHF, congestive heart failure, has a lot of different components to it, and the purpose of this slide is to try and break that down in order to get the most specific data and the best documentation. A question that frequently comes up is, what if the principal diagnosis is uncertain? It is okay to be unsure of the exact diagnosis. There are 4 words that can be used: probable, suspected, likely, and possible. If the diagnosis is documented during the hospitalization or at the time of discharge with the following those words, it can be coded as if it existed. There can be a disconnect between clinical and administrative functions, so we must be clear and specific in what is documented, because coders cannot assume a diagnosis from your documentation. And much to our dismay, coders are restricted. They cannot code directly from nursing notes, therapy notes, and symbols and abbreviations, or assume what they meant. They can gather clues from those notes to query physicians for proper documentation to lead to more accurate coding. Specificity is very important. Also keep in mind that medical record documentation from any physician involved in the care and treatment of the patient, including documentation by consulting physicians, is appropriate for the basis of code assignment as long as there is no conflicting documentation from another physician. Using the words due to provide precision in the documentation. So if a patient is admitted with a sign, symptom, or some other ill-defined condition and is later found to have a definitive diagnosis, you should clarify your documentation by using the phrases due to or secondary to. For example, nausea and vomiting due to suspected viral gastroenteritis, syncope due to orthostatic hypotension, dyspnea due to an acute COPD exacerbation. Due to or secondary to are important phrases to use, especially with the symptom diagnoses or the intractable diagnoses. The phrase due to is inferring a relationship between the processes. Status post does not infer a relationship. It suggests that the patient had the diagnosis in the past and it is no longer present. Examples are given here. Continuing with definitions, secondary diagnoses are other conditions that required clinical evaluation, treatment, increased nursing care, monitoring, or an extended length of stay. They can be chronic conditions that require treatment, such as hypertension, diabetes mellitus, congestive heart failure, COPD, Parkinson's disease, end-stage renal disease, and more. Morbid obesity can be considered clinically significant if it requires increased levels of nursing care. It may increase the risk of complications also. So remember to avoid history of and status post, as it implies that the condition is resolved and no longer acute. Completeness is a very important factor. There is a love-hate relationship mainly with dictation services and software. Yes, it does save time. It There is a need to focus on any dictation errors as one cannot determine what was trying to be documented. So the transcription reads, this is a 79-year-old patient who tents from nursing bone for evaluation of voting and diarrhea for the last 3 days and any blood in his volume or stool. What the physician actually dictated is, this is a 79-year-old patient who presents from a nursing home for evaluation of intractable vomiting and diarrhea for the last 3 days. He denies any blood in his vomitus or stool. It is so important to read what you dictate and correct any errors. Although you are not aware, there is a little difference between MSDRGs and APR-DRGs. APR-DRGs are a clinical rather than statistical model. There is an expansion upon DRGs and the AP-DRGs by also assigning to each case a severity of illness subclass and a risk of mortality subclass. You may hear this as SOI and ROM. Severity of illness is the extent of physiologic decomposition or organ system loss of function. Risk of mortality is the likelihood of dying. APR-DRGs are disease-specific and provide an accurate evaluation of both the resources used and the outcomes. The patient is separately assigned 2 distinct subclasses, severity of illness and risk of mortality. Each subclass has 4 possible assignment levels. 1 equals minor, 2 equals moderate, 3 equals major, and 4 equals extreme. If you have a patient who dies and their SOI and ROM scores are 1 or 2, then it looks like that there was a problem and the patient wasn't sick enough and died at the hands of the hospital or physician. Therefore, the documentation is extremely important. Continuing with the topic of completeness, don't leave out CCs and MCCs present on admission and hospital-acquired conditions. Present on admission, POA, is defined as being present at the time the order for inpatient admission occurs. Conditions that develop during an outpatient encounter, including emergency department and/or observation services or outpatient surgery, are considered present on admission. A hospital-acquired condition, a HAC, is a medical condition or complication that a patient develops during a hospital stay which was not present at admission. The presence of a major complication or comorbidity, an MCC, or complication or comorbidity, a CC, generally is representative of a patient that requires more resources. Therefore, hospitals are paid more to care for these patients. I'm not going to spend time going into specific CCs and MCCs. This is information that you can get from your CDI specialist. Many times I hear, is it unethical or gaming the system to add all of these CCs and MCCs and other qualifiers? There's a quote from one of the regulations that states, "We do not believe there is anything inappropriate, unethical, or otherwise wrong with hospitals taking full advantage of coding opportunities to maximize Medicare payment that is supported by documentation in the medical record." Hospitals' efforts to improve the specificity and accuracy of documentation and coding are perfectly legitimate. We encourage hospitals to engage in complete and accurate coding. The source of that statement is as listed. So it's not about money. It's about getting appropriate credit for the complexity of the work that you do and the services provided. Lastly, I'd like to provide a documentation example of a fall with a rib fracture to help get a better idea of documentation. This is an actual patient and actual documentation, and this slide shows what the physician wrote, and the subsequent slide will show what it can look like with the appropriate changes. So the chief complaint for this patient is a fall at home with hip and rib pain. The history of the present illness: patient is a 90-year-old female with a complaint of rib pain following a fall at home. According to the family, the patient fell in the bathroom and hit her left side. She was unable to ambulate after the fall. She has been on oral Levaquin for the treatment of a urinary tract infection per her PCP. She gets unsteady and weak when she has a UTI, according to the family. In the ER, the x-rays showed left-sided rib fractures from 7 to 11. No hip fracture was noted. The patient has uncontrolled pain, so she needs IV pain medication for pain control. Past medical history is significant for those items listed. Here's the confusing factor. The statement also goes is that at the time of the exam, the patient is resting comfortably. That does not give accurate documentation. That is probably showing the fact that the patient was examined later on instead of going along with the patient needs IV pain medications for pain control. And at the time of the exam, the patient is resting comfortably, mostly nonverbal at baseline due to dementia, and most of this information was gathered from the daughter. Would like nursing home placement. Well, that sets you up for a wrong statement and a wrong intention for admission of this patient. A better way to have said this, at the time of the exam, the patient is resting comfortably after adequate analgesia. The assessment and plan for this patient does not adequately describe the acuity of this patient and therefore can potentially lead to a denial of services. In conclusion, it is important to document all the things that are going on that you see, observe, and think. If you have any questions, please feel free to reach out to me. I'll be happy to answer them in the best way that I can.